Good morning, everyone. The topic of my presentation is dissociative disorders. Introduction. In ICD-10, dissociative disorders are classified. The definition of dissociative disorder is partial or complete loss of normal integration between memories, identity, sensations, and control of body. While in DSM-5, they have given the definition as dissociative disorder is a disruption in usually integrated functions of consciousness, memory, identity, emotion, perception, body representation, motor control, and behavior. So they have added this term perception. That is why depersonalization and derealization disorders are part of dissociative disorders in DSM-5 and not in ICD-10. In ICD-11, they have changed only one word, involuntary disruption or in integration of one or more. The rest of the definition is same as DSM-5. History. The ancient wandering womb hypothesis was given by Hippocrates. Then came the master organ hypothesis in 1700s, and it refers to the idea that the master organs such as uterus, digestive system, and the nerves influence the brain and resulted in nervous symptoms. And during 1800s, the spinal irritation doctrine was expanded into a reflex theory, which asserted that every organ in the body could reflexively influence every other organ. Then in Jean-Martin Charcot, conceptualized hysteria as an inherited disease of nervous system caused by functional lesion of nervous centers. So they call them functional lesions because they were presumed to exist but couldn't be localized by the techniques of that time. And after the death of Charcot, most his two successors, Babinski and Janet, took two divergent views. According to Babinski, hysteria was caused by suggestions and could be removed by counter suggestions. And according to Janet, he established the concept of dissociation. He referred to mental, behavioral, and affective state as psychological automatism. He argued that a psychological automatism could be split off from consciousness under conditions of severe stress and functions outside the awareness of voluntary control. The DSM-5 and ICD formulation originates Janet's conceptualization of dissociation, which he termed as desegregation mental. Freud followed Janet's dissociation trauma hypothesis and coined the term conversion to describe the process by which unacceptable mental contents were transformed into somatic symptoms. So the difference in dissociation and conversion. So conversion is characterized by presence of one or more symptoms suggestive of neurological disorder that cannot be explained by any known neurological or medical disorder. Conversion disorders were formerly called as hysteria. And dissociative disorders, disruption of memory, identity, consciousness, emotion, perception, body representations, motor control that result in significant impairment in general and social function. Now, in DSM-1, these disorders were classified under psychoneurotic disorders, under dissociative reactions and conversion reactions and hysterical anxiety. In DSM-2, they were classified as neurosis under the headings of hysterical neurosis dissociative type, hysterical neurosis conversion type, neurotic depersonalization, and hypochondrial neurosis. In DSM-3, for the first time, dissociative and conversion disorders were classified differently. Dissociative disorders were further subclassified as psychogenic amnesia, psychogenic fugue, multiple personality disorder, depersonalization disorder, and atypical dissociative disorder. So in DSM-3, the concept of neurosis was abandoned, and they separated this dissociative and conversion disorder, which were placed under somatoforms. In DSM-4 and DSM-4-TR, the names of these these dissociative disorders were changed from psychogenic to dissociative. Dissociative amnesia, dissociative fugue, and dissociative identity disorder. And perception was added to the definition of dissociation. Finally, in DSM-5, dissociative disorders are classified as dissociative amnesia, dissociative identity disorder, derealization disorder, and depersonalization disorder. So, derealization disorder of depersonalization, earlier in the earlier editions of DSM, there was only derealization disorder. Depersonalization was added for the first time in DSM-5. And dissociative fugue is now no longer a separate diagnosis. It is now a specifier for dissociative amnesia. In ICD-9, they were classified under neurotic disorders under hysteria. conversion disorder, psychogenic amnesia, multiple personality disorder, and fictitious disorder. Now, differences in the nomenclature. Currently, DSM-5, ICD-10, and ICD-11. In DSM-5, they are classified as conversion disorders, which is now in DSM-5 called as functional neurological symptom disorder, which is a part of somatoform disorder. In ICD-10, 10, there is dissociative motor disorder, dissociative convulsions, and dissociative anesthesia and sensory loss. And in ICD-11, they have called it dissociative neurological symptom disorder with a subspecifier of with visual disturbances, with auditory disturbances, with vertigo, dizziness, with other sensory disturbances, with non-epileptic seizures, speech disturbances, paralysis or weakness, with gait disturbances, movement disturbances, and cognitive disturbances. Dissociative amnesia in DSM-5 has a specifier of dissociative fugue. In ICD-10, it is dissociative amnesia, and 11 also there is a dissociative amnesia. Now, in DSM-5, it is dissociative identity disorder. At the ICD-10, it is multiple personality disorder under the heading of mixed dissociative disorder. Then in DSM-5, there is a dissociative trance under the heading of other dissociative disorders. In ICD-10, it is trance and possession disorder, while in ICD-11, they have divided it into two, trance disorder and possession trance disorder. Now, ICD-11, there is a new category introduced, partial dissociative identity disorders. Then in DSM-5, it is depersonalization derealization disorder. In ICD-10, it is depersonalization derealization syndrome, which is classified under neurotic disorders. And it is in ICD-11 depersonalization derealization disorders. Now, the diagnostic criteria. These are the classifications under DSM-5, ICD-10, and ICD-11. Dissociative amnesia. It is characterized, the characteristic of dissociative amnesia is first type of memory loss. Episodic memory, which involve first person recollection of specific events. Then there is a temporal structure. Memory loss is for one or more discrete time period ranging from minutes to years. And type of the event forgotten are usually traumatic or stressful events. In ICD-10, the diagnostic criteria is amnesia, either partial or complete for recent events that are of traumatic or stressful nature. And then there is absence of any organic brain disease, intoxication, or excessive fatigue. In DSM-5, they have written it specifically that amnesia for autobiographical events, usually of traumatic or stressful nature, that is inconsistent with the ordinary forgetting. The symptoms cause distress or impairment in the social, occupational, and other important areas of functioning. There should not be any organic brain disease. And DSM-5, the criteria is same as ICD-11, the criteria is same as DSM-5. Now, type of amnesia, it can be localized. In this, there is inability to recall events related to a circumscribed period of time. It can be selective. The ability to remember some but not all the events during the circumscribed period of time. Then continuous failure to recall successive events as they occur. Systematized individual lose memory for a specific category of information, like a memory relating to a family or a particular person. And then there is generalized, that is complete loss of one's life. Procedural memory, semantic memory may also be affected and associated with purposeless wandering. In dissociative fugue, there is purposeful wandering. It is purposeless wandering in amnesia. Now, the differential diagnosis is post-traumatic stress disorder, neurocognitive disorder, substance use disorder, post-traumatic amnesia of brain injury, seizure disorder, catatonic stupor, and fictitious disorders. Now, the depersonalization, derealization in ICD-10, it is classified under other neurotic disorder, F48.1. It is perceived change in the mental activity such that thoughts, body, or surrounding feel unreal. It is automatized, loss of emotions, feeling detached. In this, the insight is present and it should not be due to schizophrenia, depressive disorder, phobic disorder, or OCD. In DSM-5, depersonalization is defined as feeling detached from oneself, feeling as if observing oneself, sense of unreality, sense of distorted time, and sense of distorted perception. And derealization is sense of unreality and feeling detached from one's surrounding. In this, insight present and it should not be due to substance use and other medical condition, and it should cause marked distress and impairment. In ICD-11, the criteria is similar to DSM-5. Now, dissociative identity disorder. That is coexistence in the same patient of identities attributed to either possessing entities or to endogenously generated self-states. ICD-10, it is listed under other dissociative disorder as multiple personality disorder, and symptoms are not detailed. In DSM-5, the sense of one's identity should be distorted, sense of having two or more personality state, each with unique sense of self-control, affect, behavior, memory, perception, and sensory and motor functions. There should be recurrent gaps in the recall of everyday events that are inconsistent with the ordinary forgetting. It should cause significant distress, and it should not be a normal part of broadly accepted cultural or religious practice, and symptoms are not due to substance abuse or other medical conditions. Again, in ICD-11, the criteria is similar to DSM-5. Then in ICD-11, there is partial dissociative identity disorder, 6B65. It is same as dissociative identity disorder, except one personality is dominant and normally functions in daily life and is intruded upon by one or more non-dominant personality state, dissociative intrusions. And the non-dominant personality state do not recurrently take executive control over individual consciousness and are occasional. In trance disorder, ICD-10 defines trance disorder as trance and possession disorder, temporary loss of both sense of personal identity and full awareness of the surrounding. In DSM-5, it is classified under other specified dissociative disorder as dissociative trance. It is narrowing or complete loss of awareness of immediate surrounding that manifests as profound unresponsiveness or insensitivity to the environmental stimuli, may be accompanied by minor stereotype behavior that are outside one's control and that are not a normal part of broadly accepted cultural or religious practices. In ICD-11, they have classified it as trance disorder and possession trance. In trance disorder, it is the definition is the same as DSM-5. There is no loss of personal identity, not a normal part of broadly accepted cultural or religious practices, not better explained by another mental behavioral disorder, not due to substance use and cause significant distress to the patient. In possession trance, there is a narrowing of the awareness of the immediate environment plus loss of personal identity. Now, the various theories for etiological theories for dissociation. First is information processing theory. It was given by Hilgard in 1973, and they called it neo-dissociation theory of divided consciousness. So this theory conceptualized that the mental apparatus consists of a hierarchy of connected cognitive structures that monitor, organize, and control thought and action. The cognitive structure at the top of the hierarchy, which is called as executive ego, exercises a executive function over a set of lower level of control systems or schemas. Schemas are able to function with considerable degree of autonomy from ego once selected. So, so they may become dissociated from the executive control with their continued operation occurring outside the awareness. In this way, well-learned behaviors can be performed effortlessly and concurrently. Now there is this discrete behavioral stat model, which was given in 1980s. He postulated that states to be a fundamental unit of organization of consciousness. According to this model, dissociative disorders are characterized by individual consciousness being organized into series of discrete mental and behavioral states, characterized by specific affect, body images, modes of cognition, perception, memories, and behavior. In patients with dissociative disorder, transition between individual states remain abrupt and discontinuous. Now, there is taxon model of pathological dissociation, which state that taxonal analysis suggests that a categorical division of dissociation, the normal, non-pathological, and categorical. Constitutional factor, powerful emotional event contribute to creating individuals who are different from normal individuals. It assumes that pathological dissociation, such as dissociative identity disorder, represent different type of taxon. Now, there is a trauma model of dissociation which suggests that dissociation is psychobiological response that enhances individual survival during and after traumatic event. According to this model, dissociation allows individual to automatize behavior, experience analgesia, separate mental experience from physical ones, and compartmentalize devastating experience. Then there is a fantasy model. Relationship between reported trauma and dissociation is due to fantasy proneness. It is personality trait consisting of mild form of cognitive or executive function impairment that predisposes individual to being suggestible and generally prone to fantasy, and have specific liability to confabulate traumatic experiences. Now, assessment of dissociation. So we have various scale, dissociative experience scale given by Bernstein, clinician administered dissociative state scale, multi-scale dissociation inventory, child dissociative checklist, adolescent dissociative experience scale, and detailed assessment of post-traumatic stress traumatic specific dissociation scale. Dissociative experience scale was given by Bernstein. It is a 28 item self-report instrument, and the respondent has to slash a line to indicate the score anywhere from 0 to 100 for each item. The overall DES score is then obtained by adding up 28 item and dividing it by 28. This yield the overall score ranging from 0 to 100, and a cutoff score is 30. Now the management. There is no clear treatment guidelines available. Non-pharmacological treatment has been found to treat this disorder effectively. Adjunctive pharmacological interventions can symptomatically helpful in these cases. So this is a algorithm which shows how to start a how to give a psychotherapy to the patient. These are my references.